Good morning, everyone, and welcome to Community Conversations. I'm Robin Shapiro, and I am the board chair of the Washington State Health Advocacy Association. We are delighted to welcome you to another interesting discussion about COVID. And also today we're going to be talking about hospital advocacy. We're very fortunate to have three professionals who are going to be sharing their knowledge from the front lines. First, we'll be leading off again with Dr. Dale Reisner, who's medical director and WASHA board member, medical director at Swedish Health Services of OBGYN Quality and Safety. And we have two social workers from hospitals in our area, Isabel D'Ambrosia from UW, that's University of Washington, and Ashley Oeveren from Snoqualmie Hospital, which is more of a community hospital. So to start off, Dale, can you go ahead and start us off with what we've learned in the last week, or what we haven't learned in the last week about COVID?
Yeah, and so since we have two great guest speakers, I'm not going to spend a lot of time. As always, I will be available for questions at the end, or if there's something that I touch on that you want further expansion, just let Robin know and we'll go from there. So what I wanted to do was focus a little bit more on national status and then a little bit of a drill down as to what's going on in Washington State. Nationally, we are up to, I've got numbers here because I've been wasting paper like crazy. So we are up to 56,000 cases, 58,000 cases per day for the country as a whole. As you know, if you've been looking at the news at all, there's been ongoing swarms in a handful of states, and I'll talk about where they're at. Our total number of confirmed cases in the United States is 4.3 million, and we have almost 150,000 deaths, 149 plus. So a sad status report. California is up to 459,000 confirmed cases and 8,000, almost 500 deaths. So that is the highest state right now. It's surpassed New York, not a good statistic to strive for. Florida is next with about 425,000 confirmed cases and 5,800 deaths. New York is 416 confirmed cases with 32,000 deaths. And that stemmed from their initial huge surge. And subsequently, and I will just say that subsequently they have done a really good job of bringing that down and really slowing the progress dramatically. I don't know if you've seen, there are pictures of central New York that still looks very desolated. And so I think they've been able to, their deaths would have been even worse had they not really clamped down tightly on the city. Obviously, that has other repercussions. Texas is up to almost 400,000 cases with over 5,000 deaths. Mm-hmm. And Jersey is the fifth with the highest volume. And as you know, Arizona has had a big sweep in cases. It's a smaller state and less populous, so their numbers are not quite as high as the ones I just mentioned, but it's everywhere. And there are only a few states where it's been a very minor impact. And places like Alaska, which had a tiny amount of COVID-19 cases to begin with, is seeing more cases now because of people coming into the state. So the fishing industry in particular, there have been some whole boats where everybody on the boat is infected. It'd be very hard to stay physically separate on these fishing boats. So the moment you let down your guard, really, I guess, is the message. This is what we see. And there were some projections I wanted to share that are pretty interesting. And I think for the people that are on this call, it's a great message to spread to your family, spread to your clients and your patients. Cases that have been predicted based on ushealthdata.org, death projection, there's a little bit of a lag. So if we look at observed, the last time they have actual observed cases, and this is across the country, is on 7/15, where there were and this is looking at deaths, there were 753 deaths on that day, on July 15th. The projection for a month from then, so we're not that far from August 15th, is 965 per day, or on that day. If we look at what's happening with easing of restrictions, it goes up to 985. And if there is very proscriptive use of masking, it drops down 300. And this is deaths.
To 300 or to 600?
300 less, so 650 instead of 960.
Yeah. With good mask usage.
With masking, yes, yes. So big plea for that, and for a sort of grade school, like on the last presentation where I showed people how to use their masks appropriately and take them off, and then good hand washing pre and post. And those of you that are in hospitals, this, but even in hospitals, I see people not doing, we're still tracking normal hand washing on all units that are not COVID. And you see people thinking that gloves are going to save them by just putting gloves on. We need to cleanse before we put them on, and then we take them off, and then we cleanse again. When you go out to the store, it's probably better not to wear gloves, actually, because just the act of taking them on and off, you're more likely to contaminate yourself if there is virus there than with your hands, where you can gel them right away. So there's those two things: facial protection, eye protection, and a proper mask. There's a new warning out, and I've seen people walking around with this mask with vents, because that may protect you, but it's not going to protect me from you. With those vents, out comes whatever you're breathing out. So those vents are more comfortable for people to wear. And I guess if that's all they can tolerate, then it's better than nothing. But you always want to wear your own mask so that you can protect yourself from somebody else. And there's a big shift in what we said self-masking would do. It used to be, it'll keep your germs inside and you'll not pass something along asymptomatically to somebody else, but it does work to protect you as well. So just wanted to comment on that. And tying in with that, as of Thursday for Washington State, there was a new mandate that took effect on Saturday, and that is face masks required in all common spaces. So it was always in stores and businesses and that kind of thing, or has been that, but all common spaces. And that's in response to the increased cases we've seen in Washington State. We still have flurries of cases in Yakima County, but King County has also seen an increase. Everywhere that there's been a lightening up of the physical distancing and opening up into different phases is where we've seen cases increase.
So just for people who are not in our state, Yakima is the kind of the farm belt area of our state.
It is. Lots of essential workers, lots of families that live in close proximity to each other. We've had in King County, our most populous county, we've had higher rates recently in those same essential workers, healthcare assistant workers, restaurant workers, any other business where they're totally reliant on that. They often don't have unemployment coverage, and they need they need that money to survive. So that's kind of where I wanted to stop right now. And
can we ask you a question, Dale? And this comes from Margaret Monsroff, and actually I'm kind of curious too, because I have college age kid, and so our kids are considering going back to college, right?
Right.
And so is there any data on hospitalizations among age groups, and any advice or consideration in terms of college kids returning to campus?
There's not really, still the case numbers are lower in those groups, but not zero. And you're starting to see, I think it's great, you're starting to see people like young folks from Florida where they went out and partied and didn't think that the masks were necessary and so on. A few of them are getting seriously ill and saying, you don't want this, please, please listen to me, I was wrong. So that is super helpful to hear, that they are really supporting masks and avoiding those kinds of gatherings. Restaurants and bars and churches are the places where we have seen the highest transmission. I'm not even going to call out nursing homes because those people are captive. And so, that's a very different subset, and for sure they're more vulnerable. But for the bulk of the population in this country, new cases are not just asymptomatic people who are asking to get tested. They're people that have symptoms or were exposed, and it's real. So you can tell it's real by the number of hospitalizations and the attendant number of deaths that go with it. There was a recent report out of Texas with a sad number of 82, I think, babies that have tested positive, 2 years and younger, including a death in the first year of life. So, it is not benign. It's lower risk of those serious diseases and complications, but it is not benign, and nobody needs to, the vaccine is the way to get protection whenever that's available. And in the meantime, people need to be really careful. Yeah. So I did want to mention, and I'll just really highlight it because I want to hear from our two guests, but also last week on Wednesday, I believe, the CDC released some new guidelines and talking about isolation and precautions for adults that have COVID-19 or have just had COVID-19. And you can find that, and we'll have that on our website at the CDC website, specifically targeting all the information about COVID-19. And there was 7 pages of recommendations. A lot of that is references, which is really nice if you want a deep dive. There were a couple of key things, and I know there'll be questions, so I'm just going to say them fast. For patients with mild to moderate COVID-19, they have not recovered replication competent, or the virus that is able to continue to infect any later than 10 days after symptom onset. So this is for the mild to moderate cases. And this is
wait a minute. Back that up. So for people that have mild to moderate symptoms, they are not infective mostly after 10 days.
Replication competent virus is what they call it. So that would be shedding virus that could be able to replicate in another host. Yes. So
basically the bottom line is that the reinfection rate appears to be maybe a shorter window than previously thought.
So reinfection is a little bit different. So reinfection would be getting infected in the same person, which we have not seen any evidence of in 6 months anywhere. But The ability to, so if you are a healthcare worker or anybody that's on this phone call and you get COVID-19 and you have the sniffles, mild symptoms, in 10 days, you should not be at risk to infect somebody else with your virus. Now, we're being cautious in the Swedish system where I work. We're saying 2 weeks from symptom or positive test, because now we're testing pre-surgery for people in many places in Washington State, pre-surgery and pre-induction or pre-cesarean section in the OB population. And those folks from date of testing, we're assuming that 10 days after that, they should not be able to infect anybody else. And the other piece of information out of this article that I think is quite reassuring is actually a shorter time frame than that, and that was for people that work in and around patients with COVID. They did not see, let me get it exactly correctly. They looked, it was a large contact study. This comes out of China, doing contact tracing, and in high-risk household contacts or hospital contacts, infection was not noted if the exposure to the case patient, the patient with the COVID, was greater than 6 days.
So say that again.
The highest period of time that a patient is infectious is 6 days from onset of disease. And they were looking at patients that were, again, household and hospital, not necessarily ICU, but when they looked at contacts that were exposed and worried about being ill or infected, if they started taking care of the patient or went into that household beyond 6 days of the infection, none of those people got sick.
So, and
that 6 to 10 days that we're talking about, as opposed to some concerns initially that it was like 3 weeks that could, potentially be infectious.
We do have a comment from Ray Drazen, and I don't know where Ray is from, but she said that she has a client who tested positive after 15 days post symptoms.
Yeah.
This positivity represents not infectious particles, rather fragments of virus particles that are still remaining, but are not considered infectious. Is that correct?
That is totally correct.
Okay.
So what this document, and this will be my last comment on this, and if we have time at the end, we can revisit, but what this document is saying is we should stop doing as much testing as we have been doing. So for instance, in the OB population, because we're doing, probably half of our patients are either planned C-sections or inductions at a high-risk center, we have been allowing partners, if the patient had COVID or the partner had it earlier in the pregnancy, we would test the partner and we would require 2 negative tests before we would let them come. We need to stop that and quit testing them if it's been at least 10 days. And we're, like I said, we're going to use 2 weeks because it's cleaner. So it really is going to allow us, as this percolates through to all the people that make these decisions, all the infectious disease experts in the different hospitals, it's going to allow us to back off a little bit. All of that testing is expensive, it's onerous, and people need to feel secure that they're good to go, and what they say about symptoms, just to make this really clear, if I start with a fever and I'm tested and I've got COVID-19, then my fever needs to be gone without me using Tylenol or NSAIDs to bring my temperature down. So without any of those kinds of medications, my fever needs to be gone. My symptoms need to be resolving, not gone, because we know some people have a cough for months afterwards, and fatigue is another one that drags on. My symptoms need to be resolving, and it needs to be at least 10 days from either the onset of symptoms or my positive test.
Great. Great. Thank you.
Mhm.
That's great. And there's a lot to dig in there. And
Yeah,
we're
it is.
talking about maybe even doing a call just about the kind of sciencey stuff around this. But today we're going to actually be focusing on hospital advocacy and how people can be more effective given this time. And so I'd like to now turn the video over to Isabel D'Ambrosia, and she'll introduce herself and what her role is. And Isabel, thank you for joining us.
Hi, can you hear me okay?
Yeah, great.
Okay, yeah, my name is Isabel D'Ambrosia. I'm a social worker at University of Washington Medical Center at the Northwest Hospital campus, and I work primarily in the intensive care unit. So we've seen, a fair amount of COVID patients. Primarily the ICU patients are patients that are on the ventilator. I was talking earlier, we have 15 beds in our intensive care unit. We have never been full. We have never been overwhelmed. We have plenty of capacity of ICU beds, and I think that probably goes for the entire Seattle area, since I know we're not overwhelmed. And we would be, I think, if the system was at capacity. But it's been really difficult. I think, kind of the thing, there's all sorts of things to struggle with, but I think we see the struggles of family because their visitors are not allowed. And we've recently moved to a policy where every patient in the hospital is allowed one visitor a day. But for the COVID patients, we're really not allowing visitors because we're so concerned that families would be carrying the disease. And a lot of times the families are sick, or there are other family members that are sick. So that's been very much a struggle. I had a patient that had 4 young children, and that we put a big red heart on his window because the kids and the mom and the patient's wife could stand in the parking lot and they knew where the dad's room was.
Oh.
And he was on the vent. But just, little things like that, I think it helps. Getting to know the patients, tell us who you are, tell us where you're from and who your people are, and what you like to do, and tell us who you are, because the stays on the vent, if you're on the ventilator with COVID, it's 2 weeks. I have a patient right now that will be longer than 2 weeks.
So Isabel, can you tell us when people are admitted, what's the best way to communicate who that patient is so that you all know who that patient is and what they're all about? Do you have any suggestions for that?
Yeah, communication will be primarily by phone, of course. And I think that the leader for that, and the doctors here at least, have been really wonderful about communicating with patients on a daily basis. When you have a patient here with COVID on the ventilator, the doctor will call you every day. Also, communication with the floor nurse, the ICU nurse following your patient, is really pretty easy. And calling and talking to the nurse, sometimes nurse and doctor will do updates together. That channel is open. Also asked to talk to the social worker, of course, and especially about these more broader things. But the doctors are curious about you, and part of that conversation, it can be about who you are. That lines of communication. One of the things that I wrote down is, watch your phone, make sure if you're that family member's key point of communication, watch your phone, make sure that, because they could be calling several times a day. It's been a learning curve for the doctors to figure out how to treat this disease. And so, but they have been very good, I feel, at communicating with families. And we can use, patients that have their phone. We've been doing FaceTime with patients that are in the intensive care unit. We have an iPad here, a couple of iPads in the hospital that we can use for communication, just so that families can get a visual, if they like that, with the patients that are isolated on the ventilator. So
I know that a lot of advocates often ask to be included at shift change. Is that in terms of making sure that information is transferred. Is that ever a request that could be accommodated in these times where, you know, people would have to be by phone, or
Yeah,
how would that work?
I don't know about shift change, because then that they're talking very rapidly about a large number of patients at the shift change. So I'm not sure the shift change would be the best thing. We do patient care rounds every day, and we round any patient that's on the ventilator. We do a patient care rounds where we round with the doctor, the nurse, dietitian, pharmacy, respiratory, and me, and social work. We round on that patient every day. They could ask we could definitely phone people in for the patient care rounds. It's probably a 5 to 10 minute discussion of the patient with all those disciplines there. And that's something you could ask to be included in. We haven't done a ton of that. It's very technical. You know, as the social worker, I'm kind of like, what? I don't always get it. It's a very technical round, but sometimes families could hear that too. In normal pre-COVID times, families are quite often at the bedside and do definitely listen in at patient care rounds. So that's a good thing. One other thing I wanted to bring up is think about, everyone should think about who is my next of kin? Who would be my medical decision maker if I got so sick I couldn't make my own medical decisions? And just making sure that you know the hierarchy of who would be your next of kin, and do you want that person to be your decision maker? Does the hospital have the name and phone number of that person? And then of course, thinking about advanced care planning. Do I want to spend 2 weeks on a ventilator? That it's something that, to be thinking about, especially for older people with a lot of comorbidities, where it could be a very difficult hospital stay for COVID.
And we do have Bonnie Bazell, I think, is on the phone, and she works with Honoring Choices, which does advanced care planning. So I just wanted to give a little plug for her organization. We've talked a little bit about that along the way. Isabel, could you also talk about the role of the social worker as advocate and what you specifically do in the ICU, especially as discharge planner, like what that looks like and what are the elements that go along with that?
Yeah, I am the discharge planner. That's kind of my central role, or one of them anyway. That asking about the discharge plan is really important. Where is this going? Social work, that's kind of how I introduced my role primarily as the discharge planner, and thinking about, well, how's this disease going to affect you? What is going to happen to you when you're ready to leave the hospital? Are you going to need a rehab stay? Are you going to, do you have enough family at home to support you at your, if you're going to be weaker after that? We do a lot of talking about that. So that's kind of our primary role, is thinking about, well, where were you living before you got hospitalized? How sick were you? How was your mobility? Were you moving around okay before you got this disease? And then talking about, what can we help you with when you're ready to leave the hospital? What are you going to need from us or from the system when you're ready to leave the hospital? That's kind of our primary role. We do definitely keep an eye on communication, checking in with family, just making sure that, how are the discussions with the doctors going? Are you understanding everything? Is there anything that we're missing? Just to check in, to just kind of, because doctors can be very, information goes out a lot, and a lot of times families are, talking back to the doctor or asking a lot of questions can feel kind of intimidating. So just checking in to make sure that communication's going well is kind of a part of our role too. And then
we have a couple questions coming in here. So one is, should every COVID patient coming into the hospital have an advance directive to state whether the patient would want to be placed on a ventilator?
Ideally, yeah. People don't, but honestly, just a conversation with your family about it is super helpful. Things that are written down are not carved in stone. It's really about your family's decisions on the fly. So a conversation with that person, your next of kin, that is great. But yeah, writing it down is wonderful too.
So this question from Iodoka, what is the ratio of people getting off the ventilator and recovering at your facility?
That's a hard question because, and that could be a whole nother discussion. Our palliative care service has been very active because they are really meeting with patients. We at Northwest Hospital, I mean, we're basically a community hospital too. We work with a lot of patients that come in from nursing homes, and we've had a lot of our COVID patients have been from nursing homes, and palliative care gets right in there right away and really talks seriously with family about what would be the goal of a long stay on a ventilator for a patient that's already quite debilitated and living in a nursing home. So the patients that we've mostly had in the intensive care units are, in their 50s and 40s. And
wow.
Because our palliative care discussions have been so strong.
Yeah. So I'd love to quickly get Ashley in here to make sure that we hear from her too. So Ashley Oeveren is from Snoqualmie Hospital. And can you jump in here and talk a little bit about your role in your hospital? It's a little bit different than Isabel. Where is she? There we go. Oh, there we go. Let me try to unmute you. There you go.
Can you hear me?
Yes. Yes.
Yeah, no, so it's actually a really good segue, I think, because so the hospital that I work in, we're a rural hospital, which basically means that we're very small. We have an emergency room, we have clinics, we have a lot of services that are offered in the standard hospital. By and large, our inpatient population is people who are accessing a skilled nursing benefit. So in a sense, the department that I work in most, which is our med surg with all of our inpatients, is folks who are utilizing a skilled nursing benefit. So in that sense, my background is a lot more geared towards like skilled nursing facility, nursing home, long-term care type of social work. We don't provide any long-term care though, so I'm also doing a lot of discharge planning and and working with our ER when needed. So anyway, yeah, but that to say, I mean, just to go off of what was already said, I would say, a lot of the people that we are now seeing getting referred to us from acute care, because that's where all of our patients come from, they're referred to us. They're people who are, needing skilled nursing, so they're debilitated in some way. And I would say that because of COVID, there's less people going into the hospital for like knee replacements, hip replacements, the things that we might typically be working with. So the folks that are now coming to us are very sick, or have been very sick, are on the heels of being very sick. So it's been a really, I would say, a relatively big shift for us, just because usually we have kind of a mixture of people. And now the people that are coming, like, they did not want to be in the hospital. So there was already a lot of fear going into the acute hospital to get treatment for whatever it was that you needed to get treatment for, if it wasn't COVID. And then they're coming to us, and that fear just sort of continues, right? Because the acute care hospitals need to keep their beds free. And so if you fall and break your hip, typically you might be in the hospital, acute care stay a little bit longer. Now the acute care stay is a little bit less, and they're coming, kind of coming to us quickly. So that's been a bit of a shift for us. And so I think like some of these folks that are actually coming post COVID, who've been on vents, who've been, through this whole process. I mean, they're some of our most, I've just learned some incredible things in talking to them. It's like you've gone through a war and come out the other end. And so it's actually a lot of the things that I would recommend, I'm learning from them based on what they, relayed in their experience. But I guess I would love to, I just want to second and third that idea of being prepared before you go in. have a conversation. I feel like we should probably all now, especially if you're a caretaker or have older patients or, people that you're working with, have a plan now. What will happen if you get sick, not even just with COVID, but if you need to go into the acute care hospital, what is the plan? And be prepared going in, because whatever you come in with into the emergency room, that's kind of what follows you, right? So if you have a good plan and a contact person sort of already identified, that helps to get us moving quickly in the right direction.
So Ashley, are you seeing in your hospital the role of advocate, either within the family or professional advocates? And
Yes.
how is your hospital working with those folks ideally?
Yeah. So, as a social worker, this has been a really interesting time, because we've always been the advocates, right? But now especially so, because we can't replace a family member sitting by the bedside. We just can't. We don't know that patient the way their family does. We're not inclined to ask the same questions, because we don't know to ask. We don't know what's what's on the mind of the family and the patient. And so getting to know our patients and their families has been a huge thing. That we always try to get to know our patients and families, but now even more so. I'm spending probably like an hour and a half on the phone, with folks as they're coming in, just to who's important to you, who do we need to update, how do we keep people in contact, right?
Yeah, I'm also curious. Because we've talked a bit about being prepared, and there was one presenter who actually recommended doing a piece of like 8.5 by 10 kind of poster about who that person is, what are their likes, and what matters to them. So if a family member were to bring that in or send that to you, would hospitals be inclined to post that if requested? Is that something that families could do or advocates could do?
Yeah, that's a great idea. We actually recently had a patient who came in and he had a stroke, and he had pretty significant memory loss, and just really had a hard time communicating what he needed to communicate. So his family put together a big poster that just gave, and it was information that, it might seem trivial, but for us, it's really important. Like, I like to watch baseball, and his, I have 2 cats, their names are X and Y, and they're important to me. And then the biggest thing, they had a big portion of, here are the important family members in my life, right? And who to contact. And it was kind of in an order. So we had a place to start. Because if we don't get something, all we have to go off of is what comes from the acute care hospital setting. So one thing, I think, if you know that your loved one patient, who, whatever the connection is going to go post-acute for care, in that process of discharge planning from the acute care hospital, I would really recommend, before that person ever leaves the acute care setting, have the social worker who's working on that referral get for you some contact information. So, like, for instance, you could ask them, okay, they're going to Snoqualmie Hospital for rehab. Who's my point person there? Who do I contact? And the admissions team at that accepting facility should be able to pass on a phone number. And you can even make contact before the person transitions over. Those have been the most seamless transfers that we've had, is when a family member actually reaches out before the patient ever gets here, just to say, I'm so-and-so, I'm this connection, and these are my expectations, basically, nicely, but like, here's my phone number. I'd really like someone to check in with me when my dad gets there. Then we know going in exactly what they're expecting, and we can get an update as quickly as possible.
Great.
Ashley, I wanted to just, Kristen shared with us when she was bringing you to our community conversation that you had a dementia patient where you FaceTime with his wife at night, which completely changed his world.
Yeah.
Just those things are so important.
Yeah, we've had a couple. So the real hard thing that we've seen is patients with dementia or any kind of memory loss that are, they're already out of their routine. They're in this new setting that's unfamiliar and scary. And, there's no one familiar there, right? And there's all these sounds and things. So one thing, that particular patient, we started FaceTiming with the wife pretty regularly, like got the nursing schedule so that at a certain time nursing would do this FaceTime call, and he had all the technology in place. We had another gal recently who had dementia and was a non-English. English was not her first language. And we tried to use an interpreter. It wasn't working because the dialect wasn't quite the same. And so what we ended up doing is setting up a tablet in her room. And we had her daughters on speed dial with the tablet with the FaceTime. So if ever this patient started to kind of get a little bit frustrated, our nursing staff could just hit that pre-programmed number and it would dial up the family right away. And then there'd be a face there. It would kind of bring things back down. The family could explain what the patient was needing and wanting. And then she was able to participate in therapies. And we would even bring the iPad into physical occupational speech therapy sessions as well. So that the family could explain what was going on and why they needed to do it. And then she could do that. So yeah, iPads are our new best friend here.
Brilliant solutions.
Yeah, and Isabel, I wanted to also jump in here because you had also made a good comment yesterday when we were prepping about encouraging families and advocates to ask questions, and even if policies are stated as something, don't assume that they can't be bent. And I think some people would be maybe shy to do that. So can you tell us a little bit about that, how that works?
Yeah. Yeah, we, I was talking yesterday about our visitor policy at the hospital. And we were initially no visitors for a while. We've expanded to allow 1 visitor per patient per day. But no, especially if you're facing an ICU stay. If, patients that are talking to you or on the medical floor and they calling you and you can talk to your patient, that's a little different. But if you have a patient that's in the intensive care unit on a vent, ask about the visitor policy. It's really hard with COVID because we do worry that the patient's family might have the disease. There's a lot of worry, I think, with end of life. I have a patient today. She's in the intensive care unit with COVID, had a pretty hard weekend, and they were worried she was going to die. We will call families and ask them to come in. If we're worried that the patient is going to pass away, we are not the hospital that says you can't visit your patient when they're dying. If we know they're dying, we will have family in. And I think just for being in the intensive care unit, we work in the intensive care unit, we see patients on the ventilator with all those lines and all those drips and all those wires. We see that every day. And I remind our staff all the time that when you see that and that's your loved one and you're not used to it, it's very difficult to face that alone. And work with your hospital. If they are allowing you to come in and you don't feel like you can go on this 1 visitor policy, just know, I know here it's not always flexible, but it can be. And just ask questions and see, tell the staff what you need. And nobody at the hospital wants to be, inhumane about things. And we want to humanize all of it. So yeah, just work with us. Let us know what you need.
I
we'll
would
see
say
what we can do. Yeah.
That's very true on our front too. In fact, I think a lot of the policy changes and implementation of different programs that we've had are actually born out of families asking questions, and saying, hey, I'm concerned about this and could we do this? You'd think we'd think of everything because we're brilliant, but our families are the ones that are really giving us the ideas that are making some positive changes there.
Yeah, that's great. And Althea Halchek has offered to send us a PDF of a form on COVID choices that we might make available. And somebody else had asked if there was an example of that one pager, and I just wanted to remind people, I think I might have put it in the chat box, that we did a session on personal safety nets, and the person who did that had a suggestion for how to do that one pager. Are there any other tips that, you know, ways that we can ask questions that is respectful of providers, but helpful in kind of cutting through what a patient might need, or how often to be communicating, like what's reasonable in these times when you guys probably have heavy and intense patient loads, and what's reasonable to expect in terms of communication?
Well, it's kind of funny because I feel like we're the two opposite. So I feel like we are encapsulating a good
spectrum.
I wanted to, because that was actually one thing I wanted to point out, is that a lot of people, when they go from this higher level of care down to a facility that's more long-term, you're going to see a doctor once a week, probably, as long, if you're stable. That's Medicare's guideline. We have a no visitor policy, and I think that's at least across Washington right now. It's probably going to be a longer stay. The pace is a little bit slower, so there's not going to be the daily rounds. We round once a week. So it's like, as you matriculate down, I think you might get less communication. And that's when I think it's more important, like, keep asking, don't hound us. Please don't call us multiple times in a day or in an hour, because I've had that too. But, like, we're doing our best, and I depend on my family's, like, if they need to hear from me and I didn't get back to them when they thought I should, I depend on them to call me again and say, hey, I didn't hear from you. I want an update, and nicely, because nobody's being ignored on purpose. But it's okay if you don't hear something in a day, call back. If it's more urgent than that, maybe wait a couple of hours, call back. It's okay.
And if they don't hear from the social worker, what's the best next line of defense would you recommend?
There's, every facility is probably so different here. But just in general, I would say, if you can't get a hold of the social worker, then I would just ask, well, then who? A lot of times people will just call and say, I need to talk to X, right? But if we know what information it is that you're looking for, then we might be able to funnel it appropriately, right? So if you can't get a hold of the social worker, then I guess I would say, so then ask, okay, so I've gotten a hold of somebody, here's the information I need, who's the best person to talk to, And that's, because I think a lot of times, like, I end up fielding a lot of calls that really weren't ever meant for me, but our front desk just didn't know where to handle them, so that's totally fine. But the more information you can give us, the more we can help you.
Yeah, and for daily check-ins, sometimes it's the bedside nurse who's going to be able to answer the immediate question the family has anyway. When you're, and Isabel can speak to this as well, when you're in the hospital, sometimes it's the primary provider who is caring for the patient that would typically give you a daily report or whatever. And it may be that that person is not available. So I do feel like in embracing a sense of grace in knowing that people are doing their best, and that people are super busy, and that if there was an emergency going on, you would be hearing about it. So if your family is stable, you hear less, and that sometimes is frustrating. So working the best you can, depending on either the hospital or the facility that your loved one is in, is a great message to pass along, because I get very impatient. I'm basically a surgeon and an internal medicine doc altogether, so I'm a little schizophrenic. But, when I want to know right now, and people have busy lives. Sometimes they're not patient about how they ask. but mostly it's because they're scared for their loved one and not because they're necessarily a mean person. So that's that grace on both sides, I think, is something that we have to think about.
That's where my role in this setting as advocate has really come in, is reminding our staff, like, hey, why do you think they're calling so often? You know, because imagine what it's like to have your loved one, you haven't seen them in months, maybe, right? And this is, we're like a surrogate family member right now. It's, you know, and we're continually humbled on this end too, because it's easy to get really busy and just kind of like put it off to the side. But you're right, people are calling out of fear. They're scared, just in general. It's a scary time.
So, how, this is from Teresa Berger, how are you approaching initial family care planning upon transition from acute care to long-term care? What does that look like?
Well, I don't know, that Isabel might be the better one to answer that, but I'll, you know, we are trusting that a lot of conversation goes on before folks get to here as far as a care plan. And then once folks get here, are immediately meeting with people within the first 24 to 48 hours to assess and put together a care plan and time frame on our end. Because really, like, acute care can't predict what's going to happen in this transitional setting, you know, because we don't know until we can meet the person and assess them. But we put a lot of trust into the social workers who are referring to us, because they are having a lot of I think they're having a lot of conversations about, you know, what to expect, what to start planning for, what to think about.
Isabel?
We do have some of those conversations, but from our setting, from intensive care, and even on the medical floor, as people start to get better, one thing that we emphasize a lot is that we don't know what's going to happen, and that you go, if it's a patient that they are not able to go home or back to their previous setting, and we're looking at referral to a skilled nursing facility, a lot of the conversation is about definitely, you're not going to see a doctor every day. You're not sick enough to see a doctor every day. If you're going to the long-term care facility, if you're going to the skilled nursing facility, it's rehab primary. You're going to see physical therapy, occupational therapy 6 days a week. And we're going to see how this goes. It depends on your body. We never talk to any patient ever in any concrete way about how long am I going to be at the skilled nursing facility. Everyone wants to know that. We don't know. It depends on how your body responds to just that tincture of time that you'll get when you go to rehab and the physical therapy every day. Some people are there. I always tell them expect at least a week if you're going to go to a skilled nursing facility, but beyond that, you don't know. Medicare covers up to 100 days. So we don't set a lot of expectations about that, because every single body that goes to a long-term care, or it's not even long-term care. It's not long-term care. And I think Ashley spoke to that. They don't even have long-term care. And in her setting, you're doing a skilled nursing rehab stay. You're doing PT and OT forward to get you as strong as you can be and recover as most that you can recover. It's very focused on the physical and the functional, getting you up and moving you around. And how long that takes, we can't predict that. Yeah.
And that prep is so important, because I think that's where the frustration comes in, is people, like, when you are in an acute setting, things are changing every day, you know? Yeah. And so it's like, if you have some ailment, right, like you're seeing daily, maybe even hourly improvements or changes in that, then you go to the skilled setting, and with rehab and conditioning, we have no idea, you know, we really don't. We don't even, so I think that's where a lot of anxiety comes in initially, is just like how much things sort of slow down. Like, what?
Yeah.
I mean, when can I go home?
Yeah. And I would add to that that's a really great place for a healthcare advocate, whether it's a family member or a professional advocate, to be able to set those expectations. When you're looking at COVID-19, protracted fatigue is one of those things that can really interfere with somebody's ability to rehab.
Oh, yeah.
You see that with stroke patients as well, where they just wear out at a certain point of time, and the amount of rehab that's being offered to them is not something they can really fully do. And part of it is the patient's attitude too. So, whether depression is a piece of what's going on, really common. We're seeing a lot of that with COVID. We see that with almost any major life-threatening illness. And so for family members and advocates to ask, do you think this person needs some antidepressant? Engage in their recovery. So lots of places where somebody who's on the outside watching can maybe think about those things, whereas the immediate family and the patient themselves often doesn't have the wherewithal to ask, I feel so bad all the time, or that kind of thing.
Yeah. Well, and there's a generational thing with that too,
And Sean D'Amelio with a little help just added, it's, that could be a good time for the advocate to ask, is home health and home care together a good option to go straight home? So I think that's a really good point. And Beth Droppert says it also depends on insurance and, if it's a Medicare patient.
Yeah. We discharge a lot of patients straight home with home health. Absolutely. Tons. Yeah. Probably more than to skilled nursing facility. Yeah.
So that was a question, is in this COVID era, are you guys discharging to more or less to like nursing homes? And
it's hard.
Yeah.
That's hard. I would say probably less, because for a few reasons. Skilled nursing facilities have been closing. We've lost 3 significant nursing facilities, skilled nursing facilities, just in North Seattle in the last just a few months. It's been really significant. And patients don't want to go to the skilled nursing facility. They really don't want to go. And I have so many conversations where I'm literally saying to the patient, nobody wants to go to a skilled nursing facility. Nobody wants to do that. But your body is not ready to go home, and your body is driving the bus. And we're going to do what your body is telling you it needs. It needs rehab. But people don't want to go to a skilled nursing facility because the visitor policy is very strict there, and you cannot have visitors. And it's super. And so much news about the skilled nursing facilities having COVID and it going through the facilities is very scary. They don't want to go. No one wants to go.
And I would say like something that was said at the beginning, Dale, about like people being sort of in captivity in those settings. We feel like a huge, you feel it's a palpable difference. The level of responsibility we feel for our patients' health is so heightened, because it is true. And then we have a lot of people who go, from an assisted living facility to the ER to us, and all that time they've not seen any family members, months, and they're just embedded in like these groups of people that are, people are so traumatized.
Kai asks why the skilled nursing facilities are closed.
Why they're closing? Why they've literally shut down? That's multifactorial, and it's not just about COVID. That was happening before the COVID. It's
financial.
It's financial. It's especially Medicaid, because all those facilities have large numbers of long-term care patients. And what Medicaid pays for the reimbursement is abysmally low.
It's so bad.
It's so bad. I can't even believe they've been in business as long as they have. In our system, skilled nursing facilities are so important, and they're so poorly supported.
It's so true. Oh,
I can't, I,
The- to give you an idea, the reimbursement rate, so Medicaid reimburses, I think it's like $126 a day for somebody versus the private rate is roughly $10,000 a month if you were to privately pay. So Medicaid is paying like half of that or less.
Yeah.
$15,000 a month in Seattle for private pay.
Oh, wow. Yeah. Yeah. See, and then it just goes, and nobody can afford to pay that privately.
No.
So it's,
Yeah. So
Because the private pay is backfilling for the very poor
Yeah.
rate that they're
Yeah.
getting on the Medicaid patient.
right.
well,
It's to the point where they are having to shut down.
and
And it's
we
the
are.
fancy ones that are shutting down, the nice
Yeah.
ones.
I know. That's the
It's
scary
amazing that we are right at time at noon. I can't believe it. It's gone by so quickly. I'd like to really, really thank Dale and Isabel and Ashley for all that you're doing on the front line, and also for sharing the hour with us today. It was really, really helpful. Thanks for spending the time with us on Community Conversations. If you've enjoyed this, go to www.washa.org, support us, join as a supporter member. Also fill out your survey that you will be receiving in the email. We really want to hear your feedback. Thanks for spending the time, and this will be recorded and available for anybody who wants to listen to it later. Thanks so much. Enjoy the beautiful day.
Yeah. Bye, everyone.
Thanks. Bye.
Thank you.